joining us for the third event in our ongoing series, Emerge. I'm Maggie Harrington from Morphin, Australia. I'm actually opening the session a few minutes early tonight because we have a lot of really great material to fit in, and I don't want our housekeeping items and introductions to cut into valuable speaker time. So if you can just pop yourselves on mute if you haven't already, I'm just going to go through the introductions a bit early tonight. First of all, I just want to recap on the purpose of these Emerge events. Emerge stands for Education Meetings for Expanding Rotom-Guided Excellence. And the aim of the series is to highlight evidence-based best practices for improving outcomes for critically bleeding patients. The core focus of these sessions is to harness the knowledge transfer of Rotom-guided patient blood management strategies to enhance patient safety, optimize resources, and reduce costs. Your feedback is really crucial in developing the content of our future events, and we'll be following up with you via an email to provide a survey. So please take a few minutes to let us know what you think or what we could do better. Next, just to cover some technical details for this Zoom session, this meeting is being recorded, and the format for the session is for each speaker to present for 20 minutes, and we will then hold a quick 10-minute session for poll questions and questions and answers. Of course, we'll absolutely do our best to get to all questions live during the event, but for any questions we aren't able to get to just due to time restrictions, we will be sure to publish a list of questions and answers in a follow-up email. Another note on the poll questions, the poll responses are completely anonymous, so don't worry about getting the answer wrong. We just really want to encourage everyone to participate as a learning opportunity. We'll keep the poll questions on the screen for about 30 seconds before displaying the results from the group. Next, I'd like to introduce our fantastic Morphin Australia team. We have in Brisbane our product manager for acute care diagnostics, Craig O'Sullivan. And also in Brisbane, we have Natasha Curie. She's the acute care diagnostics clinical specialist who covers the ROTEM training and education across Queensland. Next from Perth, we have Julia Bonzer, also an acute care diagnostics clinical specialist who looks after the Rotom training and education in Western Australia, the Northern Territory, South Australia, and Tasmania. We also have with us tonight Azadeh Zargari, our systems specialist based in Melbourne. Azadeh recently relocated to Melbourne from Sydney, and she'll be looking after the Rotom training and education for all of you located in Victoria. And once again, I'm Maggie Harrington. I look after the Rotom training and education in New South Wales and the ACT. And now I'm excited to introduce our amazing guest speakers. We're honored to have 3 Rotom experts presenting this evening. Our first presenter joining us tonight from New South Wales is Dr. Erin Chamberlen. Dr. Chamberlen is a consultant anesthetist at the Royal Hospital for Women, Prince of Wales Hospital, and Royal Prince Alfred Hospital in Sydney. She has a particular interest in obstetric anesthesia and the management of major hemorrhage. She's been heavily involved in educating consultant and junior medical staff on the use of Rotom, as well as running broader educational sessions on the management of hemorrhage and transfusion medicine. Tonight, Dr. Chamberlen will be sharing some insight into the basics of Rotom and major obstetric hemorrhage, as well as providing some expertise on how you can introduce this successful model into your hospital. Our second presenter is Dr. Julie Lee, joining us tonight from Queensland. Dr. Lee is a staff specialist anesthetist at the Royal Brisbane and Women's Hospital and senior lecturer at the University of Queensland. Her special research interests include perioperative blood management, regional anesthesia, and airway management. She has submitted her PhD thesis on rotational thromboelastometry, ROTEM, in obstetrics. She has facilitated workshops and published and presented widely on this topic. Our third presenter is our global expert, Dr. Klaus Gorlinger, one of the leading international experts in the management of coagulopathy and hemostatic resuscitation. Dr. Gorlinger has over 26 years of experience working as an anesthetist, intensivist, and hemostasiologist at the University Hospital Essen in Germany, and his main passion of research is the development and implementation of point-of-care guided algorithms for goal-directed perioperative bleeding management and patient blood management. Tonight, he'll be sharing some of his expertise on algorithms and interpretation matters in managing PPH. Please be sure to visit our Eventbrite page, on Eventbrite for the full bios for all 3 of our expert speakers if you haven't already. So without further ado, please welcome Dr. Chamberlen, Dr. Lee, and Dr. Goerlinger. Thank you again so much to all of you for joining us tonight, and I'll now hand it over to Dr. Chamberlen to kick us off with the presentations. Thank you.
Hello, everybody.
Hello.
Can you hear me?
I can.
Okay, sharing screen. Okay, everybody. Hello, welcome. Thank you very much for joining us. So in essence, I'm just going to talk, firstly, I've got no conflict of interest to disclose. I'm going to talk very broadly. Sorry, about...
Erin, I don't see that we can see your screen yet.
Oh, okay. Sorry. I had the share screen, but it's gone. The ability to, okay, here we go. Can you guys see my screen now?
Yes.
Yes.
Perfect. Thank you.
And you can all hear me. Excellent. Okay. So I've got no conflict of interest to disclose. I'm going to talk very broadly about what ROTEM is and the basics of ROTEM for people that are not familiar with it. I'm going to briefly touch on what's different about obstetric hemorrhage, and the bulk of my talk will be about how you can introduce ROTEM in your department. I think the subsequent talkers are going to talk a lot more about the nitty-gritty of the evidence surrounding ROTEM. And I think after that, you'll definitely be interested in how you can introduce ROTEM in your department. So what is ROTEM? It's a monitor of whole blood coagulation. So it's a better representation of the cell-based model of coagulation. Sorry, just a sec. And it's essentially pin cup technology. So I'll just briefly show you. So this is what your ROTEM machine looks like. And this is the cartridge which is inserted into the machine. And you put a blue top coagulation tube here, and blood from that tube runs along into 4 cups. And you've got 4 tests that are run simultaneously. And as I said, pin cup technology. So within those cups, you'll have a pin, and it will rotate freely when the blood is liquid. And as the blood starts to clot, it will become increasingly restricted. And we measure that restriction graphically as a temogram. So rot being rotational and tem being temogram, so ROTEM. So you're interested in essence 3 numbers, and don't be intimidated by a temogram, but you're looking at your clotting time. So that's time to initiate clot formation, and that's usually from the start of the test until the amplitude is reached at 2 millimeters. And it can be prolonged for a couple of reasons. So low fibrinogen, clotting factor deficiencies, and anticoagulants. And then there's your amplitude at 5 minutes. So how strong the clot is, so how well your clot is performing. And the main contributors to this are your fibrinogen and your platelets. And it correlates best to predicting bleeding and product requirements. And then how stable your clot is. So does it stay strong, or does it taper off or lyse? So looking at your lysis, so if you've got hyperfibrinolysis. And then you get a graphical printout like this. So 4 tests, you'll get 4 temograms. But for the simple-minded obstetric anaesthetist, such as myself, you're really only looking at your fib-tem and your ex-tem. So it's only if you're using heparin are you interested in your in-tem or your hep-tem. So 3 numbers, and also looking at your lysis. So your fib-tem, I'll briefly go. So in essence, yes, so the clotting time to initiate clot, your clot strength at 5 minutes, and how stable your clot is. So keep it simple. We can transfer these 3 words into, these 3 things, your prothrombin time, your APT, and your fibrinogen into Rotom language. So instead of getting a number, you'll get a graph. So your XTEM, a similar traditional test is your prothrombin time, and so it assesses your extrinsic pathway. Your INTEM, a similar test is your APTT, assessing your intrinsic pathway. Your FibTEM, looking at your fibrinogen contribution to clot strength, and your HepTEM. So the HepTEM is the same as your INTEM, but without heparin, so we can see if there's an underlying coagulopathy. But as I said, for the simple-minded obstetric anaesthetist, we're only interested in your XTEM and your FibTEM. And your XTEM and the FibTEM are the same test, but the FibTEM has a antiplatelet agent reagent added to it. So you're isolating the effect that fibrinogen is having on your temogram. And you can't interpret your XTEM until you have corrected your FibTEM. So your FibTEM, you're looking at the amplitude at 5 minutes, and then in your XTEM, sorry about that. And then your XTEM, you're looking at the clotting time, your amplitude, and how strong the clot is in terms of its lysis. So in general, so some general principles and how we use Rotom and how we use the algorithm. So we prioritize the management of hypofibrinolysis. So our algorithm will prioritize it because there's no point giving fibrinogen if it's going to be rapidly consumed. So we recommend giving tranexamic acid early. And as many of you probably know, the women trial supports the use of early tranexamic acid in PPH. And then secondly, it recognises the key role that fibrinogen has in coagulation. So it needs to be given early. It's the first thing to fall in critical bleeding, and it's an independent predictor of the likelihood to progress to severe PPH. And we give fibrinogen in the form of apheresis cryoprecipitate, but some people have fibrinogen concentrate. The amplitude in the FibTEM that triggers the need for fibrinogen or cryoprecipitate is an amplitude of less than 12 millimeters, which equates to a fibrinogen of 2 grams per litre. We at our hospital have a dosing schedule because you'll need increasing amounts of apheresis cryoprecipitate depending on how low your FibTEM is. And we can share all of this information with you later. And then thirdly, platelets. So as I said before, you can't interpret your amplitude in the XTEM until you've corrected your fibrinogen. And then having done that, you assess the need for platelets. An XTEM or an amplitude at 5 minutes of less than 35 millimeters suggests that you have poor platelet contribution. And then finally, you assess the need for clotting factors. So these are in the greatest reserve. And actually, most commonly, you don't need any FFP in a lot of these patients that have significant hemorrhage. And very commonly, if you were to interpret it and you haven't corrected your fibrinogen, your clotting time is quite prolonged. And then having corrected your fibrinogen, your clotting time will normalise. So what's different about obstetric hemorrhage? Well, as we're all probably aware, the pregnant lady will have an increase in their plasma volume that is about 50% by the 3rd trimester, but they don't have a corresponding increase in their red cells, and they get a dilutional anemia. So in fact, blood loss may be quite poorly tolerated in these patients. They have a very hyperdynamic circulation, so they get an increase in their heart rate and increase their cardiac output, of which a significant proportion is going to the uteroplacental bed. So 3% in the normal lady and 30% of your cardiac output in the pregnant lady. And they have a decrease in the SVR. So when they lose blood very quickly. Coupled with that, you have disorders of coagulation in pregnancy, some of which are acquired coagulopathies related to obstetric pathology, such as preeclampsia, placental abruption, intrauterine death, amniotic fluid embolism, the fatty liver of pregnancy, dilutional coagulopathy from excessive bleeding and giving inappropriate blood products, and sepsis. And then also platelet disorders related to, similarly to obstetric pathology, and sometimes just quantitative abnormalities as well. In terms of the incidence of obstetric coagulopathy, so The incidence is high and will occur early in obstetric pathology such as placental abruption, uterine rupture, amniotic fluid embolism, and HELP. And it tends to occur late and is not as common in uterine atony and surgical tract or surgical trauma, genital tract, sorry. And these two are your main contributors to PPH. So how do you implement Rotom at your hospital? Well, it's everywhere in the UK and Europe. First of all, you've got to start by convincing your colleagues, surgeons, intensivists and haematologists that there's room for them to improve their transfusion practices. The attitude will be, why would we need to change? What we've always done is just fine. At our hospital, we started small. So it was introduced initially in cardiothoracic theatres, and we introduced a algorithm that had been used in Scotland for 20 years. But unfortunately, we didn't get good results initially. In fact, we got a paradoxical increase in our transfusion rates. What people found was that the algorithm was too complex. It was a two-dimensional algorithm. And a lot of doctors found that, in particular, cardiothoracic surgeons were concerned that less products meant that would be more takebacks. And a lot of doctors took time to accept that there was room for improvement in their practice. So what we did was in cardiothoracics is develop our own algorithm. And it's a one-dimensional step-by-step version, which is much more, which is much easier to follow. And coupled with that, we had a traffic light management plan. So we had stickers, and nursing staff could simply write down the results and write down the results from the Rotom and recognise whether or not the number was below a certain number or within a certain number or above. Red being something that was wrong and needed to be treated. Orange being abnormal but doesn't require management but would be retested, and then anything that's green is normal. One of the great things about Rotom is it's got a high negative predictive value. So a normal Rotom is very reassuring in terms of coagulopathy, and that what you need to be hunting for is probably a obstetric or surgical problem. And then sticking those management plans either on the back of your anaesthetic chart or in the patient's notes. And subsequent to our one-dimensional step-by-step algorithm, we had success with a statistically significant reduction in the FFP and platelets, reduced takebacks to theatre, and a cost saving. So having had success in cardiac, we then extended it to the other hospitals on our campus. So the obstetric hospitals, the Sydney Kids and Prince of Wales Public and Private. And we had to develop a second algorithm. So we have an obstetric and general surgical algorithm, which is, again, a one-dimensional step-by-step, which I think if you look at this, it's quite intimidating. It seems like there's a lot of numbers. But if you take a step-wise approach, then it's actually quite easy to follow. And hopefully my having given you sort of basically the general principles around Rotom and the algorithm, that would help you as well. So introducing it in a department, as I said, identify some key groups that you need to engage and get involved. Start education early. I would recommend that you start education before your technology has even arrived. You need little snippets of education and disseminate it via email, invitations to education sessions. I highly recommend Roger Browning's Obstetric Critical Care webpage, where he has examples and modules and a lot of education around Rotom. It's fantastic. Create mentors in the department, people that have an interest and people that are going to disseminate information. I have done a couple of major hemorrhage workshops that have been able to be approved by ANZCA for the emergency response, and people have been able to tick off their continuing professional development requirements for the college. And that's really had a lot of interest from consultant anaesthetists. As I said, start small, so start in a single unit and then expand from there. Algorithm development. So obviously we initially had some issues with the complex algorithm, so it's good to make it as simple as possible, a single dimensional model. And you're quite welcome, as I said, to use ours and modify it accordingly. At our hospital, we have a Rotom working party that meets quarterly, and we look at issues surrounding Rotom and how we can improve things. We're in the process at this stage of developing an electronic database in which we can audit our Rotom use. And at M&Ms, in particular at the Royal Women's, all PPHs are presented. And it's good to see how Rotom has changed our transfusion practice quite significantly. Have an empathetic approach. So it's hard sometimes, especially for more senior clinicians, to change practice. So you need to help engage them. At Prince of Wales, we have a workstation that incorporates both algorithms there. On one side, you have the cardiac and vascular algorithm, and on the other, we have the general and obstetric algorithm, and all our cryoprecipitate dosing schedules. So for adults and for pediatrics. And in the last 2 years, so in 2018, we updated our massive transfusion protocol to incorporate Rotom, and that was really important actually. And we don't call it the massive transfusion protocol anymore, we call it critical bleeding protocol. And a lot of education has been put into that. And essentially you have a non-Rotom guided transfusion option or a Rotom guided. So the non-Rotom being the opportunity or the option of giving shock packs. So just your traditional MTP or massive transfusion packs, but we don't call them MTP packs, we call them packs. So pack 1 with your red cells and your FFP and your cryo, and pack 2 with your more red cells and more FFP and some platelets, and using conventional lab tests. So it gives people the option, especially if you want products in a hurry. Sometimes it's you know, you can choose the non-Rotom approach, and then having got your Rotom result, then transfer to a Rotom guided transfusion approach. We're essentially giving red cells based on your ABG or BBG, and then all other products are guided by your Rotom. In summary, you can do it. It's simple. You need an algorithm. You must have an algorithm. My experience at another hospital when I was a trainee was that I was given a Rotom machine that didn't have the cartridge technology, and I think you need to provide education, and the cartridge technology that you have now makes it very, very easy. I recommend updating your massive transfusion protocol to incorporate Rotom, and it has the potential to reduce blood product use, reduce patient morbidity and mortality, and a potential cost saving as well. But in terms of all of that, I'll leave it up to Julie and Klaus to discuss the evidence surrounding that. Any questions?
Dr. Chamberlen, thank you so much. That was a really great talk. And we do have a question in the chat that I see. The question is, the machine that you showed has one test at a time. What is the best time before you can start another test?
That's a good question. So it takes probably sort of 5 to 10 minutes to get your initial result, and then you would act on it. And having acted on it, so getting a Fibrinogen concentrate or your apheresis cryo, then you would retest. So having given your products, you would then retest and see the benefit that it's had with your Rotom result. So I hope that answers the question.
Great. Okay, I will let you get back to the poll questions. Thank you.
So the first question is, do you have a Rotom machine at your hospital? Maggie, are there any other questions from people?
Not that I can see at the moment. Let me just do another quick look. Oh, I see another one. Do you use Rotom Live or remote viewing for your results at your hospital?
Yes, we have that capacity. Yep. Okay, so there's a 2/3 of people do have Rotom at their hospital. I'd be interested to see what people say in the subsequent poll questions.
I think the next poll question's coming up here.
Okay. Hopefully, so do you have an obstetric Rotom algorithm at your hospital? So it'd be interesting to see that the 2/3 of people that do have a Rotom machine, whether or not they have a specific algorithm that relates to obstetrics. Are there any other questions, Maggie, from people?
Yep, we have another question. Do you send a routine coag screen every time you send a Rotom?
That's a really good question. No, initially I think people were, especially in cardiothoracics, there was a tendency for people to want to do that, but it's strongly discouraged. With a standard coagulation test, you're not going to get a result for about an hour to an hour and 10 minutes. It's not going to add any information to what you've got. It's spun down plasma. It's not looking at the whole blood, and it's difficult to interpret a prolonged prothrombin time or a raised INR. You're going to find that on your Rotom. You're going to know whether or not that prolonged prothrombin time or time to initiate clot is prolonged because you've got a low fibrinogen. And I think a lot of people would want to correct a prolonged prothrombin time with FFP when in fact actually your fibrinogen is low. You will get a fibrinogen result with the standard coag test, but you can get all of that from your Rotom. Oh, that's very interesting. I mean, I'm sure some of the people who have Rotom machines might not have an obstetric, not have obstetric patients at their hospital.
Dr. Chamberlen, we have another question.
Yeah.
Have you modified your critical bleeding protocol PACS after implementing the Rotom in your management of critical bleeding?
Sorry, say that again, Maggie.
Have you modified your critical bleeding protocol PACS after implementing the Rotom in your management of critical bleeding?
Yeah. I think there was a discussion, I believe, in particular for obstetrics between hematology and the obstetric anaesthetist to modify the PACS. But at this stage, no, we haven't. But it's a good question and something that's worth considering, because I think, in essence, what all of this highlights is that very often we do not need FFP. And a lot of the complications related to massive hemorrhage relate to the use of excessive amounts of FFP. But no, we haven't modified it at this stage.
Okay, thank you for that. I have another poll question.
So the last question is, do you feel comfortable using a Rotom-guided transfusion approach? Sorry.
While we're waiting for that response, if anyone else has any final questions for Dr. Chamberlen, please feel free to pop them in the chat.
Oh, that's great. So 88% of respondents do feel comfortable using a Rotom-guided transfusion approach, which is Fantastic. I'm assuming that some of the people that responded are the ones with a Rotom machine and have an obstetric practice.
All right. Any other questions from anybody? Okay. Thank you, Dr. Chamberlen, so much. We know that you have to get back to your work, but thank you so much for joining us. We really appreciate it.
No worries. Thank you very much. Cheers.
Thank you. Thank you. Take care. All right, so we can then move ahead. We're a few minutes ahead of schedule. So if you guys do think of any other questions along the way, just make sure you pop them in the chat and we can move on to our next speaker, Dr. Julie Lee, and I'll hand it over to you now. Thank you.
Okay, can everyone see my screen there?
Yes, we can see.
Perfect. Well, good evening, everyone, and thanks for joining us tonight. So first of all, I have no disclosures, but I would like to thank a whole team of collaborators and funding bodies for my research in my ROTEM work. So tonight I'll be giving you a rundown of all the main evidence on the use of ROTEM in obstetrics, namely the Pph trial, the OBS1, OBS2 studies, and also the use of tranexamic acid, fibrinogen concentrate, and I'll touch on some systematic reviews which have been published in the past 2 years. And then I'll go on to show you the findings from our studies that we've published from the Royal Brisbane and Women's Hospital. So we established reference ranges in several different cohorts of patients, so elective Cesarean patients, labouring women, and also we compared the results from those two groups. And then we looked at the effect of both BMI and pregnancy with using ROTEM. So the use of ROTEM, as you all know already, is pretty well established in trauma, hepatic and cardiac surgery, and it is increasingly being used in obstetrics, and the evidence is certainly growing with regards to ROTEM-guided transfusion in general, in that less blood products are needed to be given due to faster blood test results being available, and the actual ability to diagnose a specific coagulopathy type and ultimately leading to patient morbidity. So we published a literature review in the Blue Book 2017 on ROTEM in obstetrics. It's the same edition that Erin has published her article in with regards to what she's just presented on. So we give a summary of the ROTEM mechanics, its utility, coagulation in association with the use of neuraxial anaesthesia, postpartum hemorrhage, and also changes that we see in coagulation in obstetrics in general. So I'll start off with a study that was published in 2015. This was by Malaya et al. They conducted a retrospective observational cohort study comparing the use of fibrinogen concentrate with cryoprecipitate. They included about 40 to 50 patients in each group, and they transfused using a ROTEM-guided algorithm. Now, fibrinogen concentrate was given to all patients who had a FibTMA5 level of less than 7 millimeters. And what they found was that ROTEM appeared to be inferior to the ROTEM-guided fibrinogen replacement therapy. Now, moving on to the FibPPH trial, this was a study that recruited women who had either more than half a litre or a litre in blood loss, depending on their mode of delivery. They had 120 patients roughly in each group who were given either 2 grams of fibrinogen concentrate or placebo. Now, overall, the mean fibrinogen level for this study was 4.5 grams per litre, and the mean blood loss was about 1,500 mils. And what they looked at was the primary outcome being the need for blood transfusion postpartum. And from this study, they concluded that there was actually no evidence for the use of 2 grams of fibrinogen concentrate being given preemptively for severe postpartum hemorrhages in the setting of a normal fibrinogen level. So just a reminder, at term, the fibrinogen level should be between 4 and 6 grams per litre. And a level of less than 2 grams per litre is roughly equivalent to a FibTMA5 level of less than 10 millimetres. And typically we see this in about 1 to 2 per 1,000 deliveries, and it's associated with an increased risk of developing a severe postpartum hemorrhage. And we know that for every gram per litre decrease in the fibrinogen level, you see about a 2.6 times increase in the risk of developing a severe postpartum hemorrhage. Now, the OBS1 study, which is the obstetric bleeding study, included more than 6,000 deliveries over the course of 12 months. And in that cohort, they included 346 women who actually experienced a postpartum hemorrhage of between 1 and 1.5 litres in total. In these women, they looked at fibrinogen levels as well as the FibTem-A5 levels, and they concluded that both fibrinogen and FibTem-A5 levels were in fact predictive biomarkers for the progression of a postpartum hemorrhage. So this led on to the OBS2 study. Now, this also recruited women who had a blood loss of between 1 and 1.5 litres. It was a multi-centre, double-blinded, randomised control trial where they enrolled over 600 patients, but they only randomised 55 patients in total. Now, women were either given fibrinogen concentrate or placebo if their fibrinogen level was 16 millimetres or less. Now, what they found from that was that it didn't actually improve outcomes in postpartum hemorrhage, but in a pre-specified subgroup analysis, they found that fibrinogen replacement is actually not required unless the fibrinogen level is less than 2 grams per litre, or if the FibTem-A5 level is less than 12 millimetres. So looking at tranexamic acid, as Erin's already touched on, the woman trial, which you've all already heard about. So it's a double-blinded randomised control trial, which was conducted at almost 200 hospitals across 21 different countries. And they looked at giving tranexamic acid versus placebo. So it was quite a large study involving over 20,000 women with a postpartum hemorrhage. And as Erin's already said, tranexamic acid given within 3 hours of delivery does reduce the risk of death secondary to bleeding in women without actually increasing adverse effects. But it didn't actually show a decrease in the risk of a hysterectomy. In the same study, though, they showed that women with a moderate level of anemia had a 50% increase in risk of developing a postpartum hemorrhage, and women with severe anemia had a 10-fold increase in risk of developing a postpartum hemorrhage. So then this led on to the Woman 2 trial, which is currently underway. It's also a double-blinded randomised control trial across 17 different countries currently. They're looking at giving tranexamic acid to prevent postpartum hemorrhage in women who are anemic. So the primary outcome is looking at the development of postpartum hemorrhage within 24 hours post-administration. And they're looking to recruit 10,000 women in the study with moderate or severe anemia. Now, as part of the Woman trial, there was a sub-study. This was published by Shaka, Still et al. They included 167 women with the postpartum hemorrhage who were given tranexamic acid, and they were able to show that there was a decrease in D-dimer levels, but there was no effect actually seen in Rotem, XTEM, or APTEM parameters. So looking at the evidence, point-of-care viscoelastic testing does improve pregnancy outcomes in general. This was a retrospective audit of over 20,000 patients at Yale New Haven Hospital, and this was done over a course of 4 years. And this included about 2/3 of vaginal births and a third needing a cesarean section. And in amongst the 20,000 patients, there were 86 women who suffered a severe postpartum hemorrhage. So that's about 0.4% of all deliveries. So in amongst that group, there were 28 women who had point-of-care testing performed. So in that group, they received significantly fewer transfusions of red cells, fresh frozen plasma, and platelets. There was also a lower incidence of hysterectomies. The volume of blood loss was also lower in that group, so 2 litres as opposed to 3 litres in the non-point-of-care testing group. And also there was a lower incidence of ICU admission in that group in comparison to the non-point-of-care testing group. And there was also a shorter length of stay in hospital in general seen in that group. Now, looking at the early use of fibrinogen replacement therapy in postpartum hemorrhage, there was a systematic review that was just published last year. So we all know, and as Erin has already emphasised, fibrinogen levels drop quite early on in postpartum hemorrhage, and low fibrinogen levels predict poorer outcomes. So this systematic review looked at giving fibrinogen concentrate within 90 minutes of a postpartum hemorrhage, and they found only 5 eligible studies, 2 of which were completed, which I've already mentioned, so the Pph trial and the OBS2 trial, which included almost 300 patients in total. And they included 3 ongoing RCTs. And all the 5 studies looked at giving fibrinogen concentrate versus placebo. But in the end, they concluded that there was insufficient evidence that early fibrinogen replacement actually improves postpartum hemorrhage outcomes. So future studies are still needed in this area. Now, one of the ongoing trials that they reported on was the final randomized control trial, and the results were actually published last month. They looked at giving either 3 grams of fibrinogen concentrate or placebo. And what they actually showed was that it didn't reduce the amount of blood loss or the need for transfusion or the incidence of postpartum anemia, but it did actually prevent the plasma fibrinogen decrease without any subsequent increase in thromboembolic events. Now, looking at viscoelastic testing in general, so that's TEG as well as ROTEM, there was a systematic review that was conducted on obstetrics that was published last year. It included 93 studies, and that's from 1989 up until last year, including over 32,000 patients. 62 of those studies were on TEG and 31 of them involved ROTEM. 2 of them were RCTs, which I've just presented, so the Pph and the OBS2 trial. Now, they concluded overall that ROTEM may actually be used to guide transfusion therapy for postpartum hemorrhage, and that both TEG and ROTEM can actually be used to detect hypercoagulable changes in association with pregnancy. But there still is a need for future large prospective high quality studies to investigate the risk of thrombosis, hemorrhage, and also just to provide guidance in general for prophylaxis as well as the management of postpartum hemorrhage. So overall, in ROTEM and its use in obstetrics, from the studies, we know that hemostatic impairment is fairly uncommon in moderate postpartum hemorrhage. Fibrinogen falls earlier than other factors. Deficiencies of coagulation factors other than fibrinogen is quite uncommon also, even during severe postpartum hemorrhage. And clinically significant thrombocytopenia is uncommon unless the platelet count is low beforehand, say during a placental abruption or a very large bleed exceeding 5 litres in volume. So next I'll touch on the findings from our studies at Royal Brisbane and Women's Hospital. So we, as part of my thesis, we conducted studies to establish ROTEM reference ranges. This was done in the non-labouring obstetric population in order to optimise interpretation of derived values. We also established ROTEM reference ranges for the labouring population, and then we looked at the difference between the 2 groups. And then we assessed the combined effect of pregnancy and obesity on coagulation using ROTEM, and this was done in the Cesarean cohort. So I'll just touch on reference values first up. Previously, they were known as normal values or normal ranges, and the concept was only developed back in the 1960s by Grasbeck and Saris. So the purpose purely is to provide a comparison set of data for the interpretation of your patient's results. So essentially, comparison to rule out disease or define health. So it's not to be confused with decision limits or transfusion figures. So generally, these are derived from healthy individuals or a specific population. So in this case, the obstetric population. And early on, it was actually usual to assume that the sample data that you obtained came from a normal distribution. But later it was actually realized that many populations did not have a normal distribution. So we all know in terms of statistics, parametric methods are only applicable in a minority of situations because of this. Theoretically, they are more reliable, but we can't be certain that the distribution is going to be normal. So at one stage, people were performing logarithmic transformations to actually make the data achieve normal distribution. But then in 1987, the International of Clinical Chemistry came out and said that a minimum sample size of 120 was required to establish reference values. And this was based on a non-parametric method where you're not making any assumptions about the underlying distribution of your data. So the frequently used convention is to take essential 95% distribution. So that's by calculating 2.5 and 97.5 percentile values, and then calculating your 90% confidence interval values. And obviously, the larger your sample size, the smaller the width of your confidence intervals. So we all know that pregnancy is a hypercoagulable state, and the fibrinogen level actually increases throughout 3 trimesters of pregnancy. And this study demonstrates it quite nicely in terms of the gradual change across the 3 trimesters with the ROTEM parameters, especially the FibTem, which is the most important for postpartum hemorrhage management. So the first large study to actually achieve the aim of being able to establish reference ranges was this one. This was a Dutch multi-centre trial which included 161 patients. However, to achieve the same, they actually had to combine both women in labour as well as women who presented for an elective cesarean section. They included women from their 2nd or 3rd trimester, and they looked at the values from FibTem for A10 and A20, so the amplitudes at 10 and 20 minutes, but they didn't look at A5 values. They didn't discriminate based on BMI, and they also included women with twin pregnancies. Now, another study that has attempted to look at reference ranges was this one by Armstrong et al., published in 2011. They included 120 age-matched healthy women, with about half of that in each of the healthy, non-pregnant and pregnant group. And they looked at clotting time, clot formation time, maximum clot firmness values. And a similar study was this one by Girard et al., similar numbers, similar inclusion criteria, except that the women they included were sampled more than once. So essentially they took samples from each trimester and also postpartum. And what they showed was that maximum clot firmness has a strong correlation with platelet count values. They didn't look at FibTem values, but that was useful in terms of showing the correlation with the platelet count. So just to give you a bit of context, at the Royal Brisbane Women's Hospital last year, we had under 5,000 births, so 4,690 births in total, and our approximate postpartum hemorrhage rate was about 12% overall. And we introduced Rotom into our hospital in mid-2014. So we've been using it for almost 7 years now. And this is our algorithm we use for both obstetric and non-obstetric patients, just as a comparison to Erin's protocols, as well as the one that Klaus will be showing you in his presentation. So you can see that this applies to everyone, except for the obstetric population. The difference is 2 millimeters in terms of the FibTem A5 value with regards to the transfusion figure. So instead of a FibTem A5 value of less than 10 millimeters being the trigger, the value is less than 12 millimeters for fibrinogen replacement to be warranted. So the first study was looking at establishing reference ranges in the elective Cesarean population. So this was a single centre study at our hospital, and we obtained ethics approval with written informed consent from patients who were recruited from our maternity pre-admission clinic. And we recruited women who had uncomplicated pregnancies and who were booked for an elective Cesarean at greater than 30 weeks gestation. And with these women, we took a preoperative peripheral blood sample, and these samples were analysed within half an hour to 2 hours. So we screened 202 patients in total and enrolled 132 patients after exclusions. These are the demographics. So you can see, so I've shown the reference ranges that we've derived from our study in the second last column for the various values for the FibTem panel. And then just next to it in the last column, I've shown the manufacturer's reference ranges, which apply to the non-obstetric population. So you can see the values that we've derived from our study are significantly higher in terms of the amplitudes at various times, in addition to the maximum clot firmness. And I'll show you the XM value. So the similar trend is seen, and also the clotting time is slightly lower than the manufacturer's reference range provided. And the same trend can be seen with the NTEM values. And then we did the same in the labouring population. So similar methodology, but we use an opt-out recruitment approach over a 12-month period. So we included women who presented to the labour ward in established labour who required either IV cannula or needed blood tests. So we screened 189 patients in total and included 121 after exclusions. And these are the demographics. So I'll just show you once again the FibTem values. So in the second last column are our values from our study, looking at specifically in bold the maximum clot firmness and the amplitude at various times in comparison to the non-obstetric reference ranges provided by the manufacturer for FibTem. So you see once again that our values are significantly higher in comparison. And I'll just show you the values for XTEM, the similar trend again, and INTEM values. So then we looked at comparing the findings from those two studies. So comparing the labouring population against the non-labouring population from the elective Cesarean study. And what we were able to conclude was that there was a greater degree of hypercoagulability seen in labouring women compared to the non-labouring cohort. And I'll just briefly show you side by side the reference ranges from both of our studies. So second last column, we have the labouring women population, and the last column shows the reference ranges that we derived from the elective Cesarean study. That's for the FibTem panel, and that's the XTEM panel. And then to look at the significance of these differences, there was a statistically significant difference in terms of all the amplitude values within FibTem and XTEM panels, as well as the clotting time in the XTEM panel, as you can see, based on the p-values in the last column there. Now, moving on to obesity, we know that it's associated with hypercoagulability, and this case control study demonstrates that there is increasing hypercoagulability with increasing BMI when they use ROTEM in this study. So we know with pregnancy, there is a 4 to 6 times increase in risk of developing a venous thromboembolism. With obesity alone, it's a moderate risk factor. And in both situations, it's because there's an increased production of procoagulant factors, as well as a decrease in anticoagulant factors. But in obesity as well, we see an interference with platelet function and fibrinolysis. Now, this is another study on obesity where they use TEG, and they looked at comparing non-pregnant lean patients with pregnant lean patients, and also against non-pregnant obese patients and pregnant obese patients. And they were able to show that obesity actually correlates more with a hypercoagulable state than with pregnancy, particularly in pregnant patients at the extremes of low and high body weight. So in our last study, we looked at the influence of obesity on coagulation in healthy term pregnancy using ROTEM, and we included 185 patients in total after exclusions, and due to the numbers that we actually obtained, we could only analyse them in 3 groups. So patients in the normal weight group, overweight group, and obese group. So just quickly, because we're running out of time. So comparing the values for FibTem and XTem parameters, you can see that there is an increase in hypercoagulability seen across those 3 groups. But because we're actually comparing 8 different parameters simultaneously, we had to correct for multiple comparisons. So in actual fact, the p-value had to be less than 0.00625 for there to be significance. So in summary, this was the first study to assess the combined effect of pregnancy and obesity on coagulation in healthy women using ROTEM, and we found no statistically significant difference in coagulability across those 3 groups. And we concluded that hypercoagulability of term pregnancy is actually greater than the increasing BMI alone, and that there was no detectable difference seen from obesity, adding to the significance of the hypercoagulability seen in pregnancy alone as measured by ROTEM. So just some take-home messages. PPH is still a leading cause of severe maternal morbidity and mortality. Both fibrinogen and FibTem-A5 levels are good predictive biomarkers for the progression of a severe postpartum hemorrhage. And we know that levels less than 2 grams per litre are associated with poorer outcomes. And we need to replace fibrinogen, whether it be in the form of fibrinogen concentrate or cryoprecipitate, when the FibTem-A5 level is less than 12 millimetres, or if the fibrinogen level is less than 2 grams per litre. And based on the evidence, we've been shown that point of care viscoelastic testing does in fact improve outcomes. Well, thanks everyone for your attention. Sorry, it was very content heavy, but are there any questions?
We do have a few questions, Dr. Lee. I was just wondering, would you prefer to go through your poll questions first and then address the questions from the chat, or do you have a preference?
No, no preference at all. I'm happy with whichever.
Okay, I think we just had a poll question appear there. Oh. Okay.
Okay,
we'll go through these and then
I guess we'll start with the poll questions now.
Perfect, thank you.
Sure, so first question is, where in the hospital is your ROTEM machine situated? So is it in your operating theatre or induction room, in your intensive care unit, in your blood bank, or in your post-op recovery area, or somewhere else? Or you might not have a ROTEM machine that's yet available in your institution. Okay, so what do we got? So mostly we're seeing 25% have it in the operating theatre complex or in the induction room. And up next is 20% in the blood bank, 15% in ICU, and 7% in post-op recovery area. So I guess that's not to be expected. Even in Queensland, it's a bit of a mix in terms of where the ROTEM machine is situated in the hospital. So in our hospital, we have it in the blood bank. I know the Gold Coast Hospital, they had it in intensive care originally. The Prince Charles Hospital that does a little cardiac has it in their theatre complex, like in the induction room. So I guess it's proven that, either method works, just depends on the institution and what you're using it for. The next question is, do you have access to fibrinogen concentrate? Okay, so almost even. So 53% say yes and 47% say no. That's interesting. We had fibrinogen concentrate introduced to our institution probably 2015, so we've had it for quite a while now. Obviously, it's been used off-label. Yeah, it's interesting to see. I guess we'll move on to our last poll question. Do you give tranexamic acid routinely to all obstetric patients experiencing a postpartum hemorrhage? So yes, at any time after delivery, or no, only if postpartum hemorrhage starts within 3 hours after delivery. No, only for severe postpartum hemorrhages, and no, only if there is evidence of hyperfibrinolysis or other. So it seems like 51% say yes at any time after delivery, and 25% say only for severe postpartum hemorrhages, and 13% only if postpartum hemorrhage starts within 3 hours after delivery, which is very interesting. 9% say other. So I'm interested to hear what the other might be, if anyone's keen to volunteer their answer.
Well, in the meantime, while we wait and see if anybody wants to volunteer their answer to that one, we do have some other questions. The first one is there a proven advantage of fibrinogen concentrate over cryo?
That's a good question. I'm actually presenting on fibrinogen concentrate at the ANZCA ASM if you're attending. So certainly there's been a lot of trials being conducted, trials that are planned, and also systematic reviews based on what's already been done. I mean, we know that in practice, fibrinogen concentrate is certainly able to be accessed a lot quicker in comparison to cryoprecipitate. And the cost, I guess you can say, is relatively similar once you cater for wastage as well as the labour costs involved in terms of thawing cryoprecipitate. Most of the evidence is actually in cardiac surgery and a bit in liver surgery, but not much has been done in the other populations. There's been a bit done on trauma. You've probably heard about the Feisty trial, which was based out of the Gold Coast Hospital. There wasn't really much of a difference. I mean, you know, you think that given the convenience of giving fibrinogen concentrate would, you know, improve outcomes, but there wasn't, you know, a glaringly significant improvement. I don't know if Klaus wants to comment on that or not.
Yeah, I think the main advantage, what we actually know, is that usually it's quicker available. It depends, of course, in the logistics. In the US, quite often you have even asked the pharmacy and they prepare, then it maybe takes even as long as cryo. In Germany, it's like a drug in the operation theater. So it takes 3 to 5 minutes to give it. And I think, of course, one advantage is we exactly know what is inside, where cryo is, of course, dependent on the donor. So for calculation, the dose, of course, you couldn't do it more precise with fibrinogen concentrate.
So yeah, that's right. So there's a fixed concentration, like you know exactly in 1 gram you dilute it down to 50 mils, so it's 20 grams per litre, whereas in cryo, it's unpredictable in terms of the amount in each unit that you get. I guess there is a disadvantage, as Klaus has mentioned, like fibrinogen concentrate is actually derived from hundreds or even thousands of different donors, whereas with cryo, it's just from a handful. So, there are pros and cons to both types of replacement therapy.
Great, thank you both for those responses. The next question, do you think TXA should be used routinely / prophylactically for all elective and or non-elective cesareans?
I don't think there's any evidence to direct us in that. Like the woman trial was one that only looked at women who had a postpartum hemorrhage, not in women who were coming for an elective cesarean who did not experience a postpartum hemorrhage. I mean, there is evidence from that study and other studies that it didn't increase the risk of thromboembolic events. This is in the setting of postpartum hemorrhage. So I think before we actually give it routinely, prophylactically, like say how we do it in say major joint surgery, like orthopedic surgery, I think we need to actually see the evidence to make sure that there is no increase in risk of thromboembolic events, particularly when women are at 4 to 6 times increased risk of developing thromboembolism postpartum in comparison to like non-pregnant patients. I don't know if you had anything else to add, Klaus, or anyone else had any comments about that.
Yeah, I would agree. So I think that a big advantage of tranexamic acid, it works so quickly. So if we inject it, it works within 2 to 3 minutes. So that means if there's no bleeding, no increased bleeding rate at all, I don't see that we have to give it to all elective cesarean sections. If we see that the bleeding is somehow unusual high, we can give it and it will work within 2 to 3 minutes. So there is no significant delay. I think the most important thing, be prepared. So it should be always in a very short time available. But yeah, I don't think that we should put it in the drinking water for everybody.
Mm-hmm.
Great, thank you. It looks like there's one last question. Have you changed your treatment thresholds for blood product administration based on this higher reference range, based on these higher reference ranges in pregnancy?
So we've kept the same transfusion thresholds. So what we have found is with the reference ranges, it kind of adds to the information out there in literature. So say if a fibrinogen level or a FibTMA5 value is, let's say, appearing to be normal based on non-obstetric figures, but say if the patient is still seen to be bleeding from a postpartum hemorrhage, then it can give us more information as to maybe this particular value is, on the lower end of the scale for an obstetric patient rather than being within the normal range. So, I mean, it doesn't really change the transfusion figure as such, but it can give you more information as to maybe, why the patient might still be bleeding, despite you being able to achieve your targets in terms of FibTMA5 values, fibrinogen levels, and clotting time values.
Perfect, thank you for that. And did you have anything else, Dr. Lee, that you wanted to show, or was that it?
If we have time, just for interest, I can show you this case. So we published this in the Anesthesia and Analgesia Practice in 2018. So for those of you who are familiar with ROTEM, or those of you who aren't, it's you can see there's a dramatic sort of tapering of those temograms. So this was a situation during the elective cesarean section where the mother actually had a cardiac arrest not long after delivering the baby. And this is the first ROTEM that we received, essentially. I was wondering if anyone wanted to comment on it. Perhaps someone who's familiar with using ROTEM, or anyone at all. And certainly shows how useful it can be.
Does anyone
even if you
want
want
to
to pop in the
comment?
chat.
Yeah, you can always speak up if you want to unmute yourselves, or you can put in the chat if you're more comfortable.
Yeah, so Ali Savi's spot on. Yeah, it seems like fibrinolysis, definitely with the tapering off, and the maximum lysis figure in the Fib10 panel on the top left, it's 100%. So obviously we needed to give tranexamic acid in this instance, along with fibrinogen concentrate and also platelets, because as Erin had mentioned before, the amplitude at 5 minutes, or the A5 value in the X10 panel is less than 25 millimeters. So that was indicated. So we gave tranexamic acid, fibrinogen concentrate, and platelets in that situation, and improved quite dramatically.
Great, thank you. And it looks like there was one follow-up question based on the last question. Have you changed your treatment thresholds for blood product administration based on these higher reference ranges in pregnancy? From your response, the follow-up question was, would you give more product based on that observation then?
I think it would depend highly on the situation. So it had to be individualized for that patient. Obviously, the range of fibrinogen levels is quite large. So it's between 4 and 6 grams per litre at term. So, it'd be, interesting to see what the baseline is to begin with before the postpartum hemorrhage. And obviously the patient would also have to be still bleeding where you hadn't gained control of their bleeding, and there was still possibly, like a minor coagulopathy that hadn't been fixed if you were basing it on the non-obstetric values. So I think that's where it would be important, where like the values may seem to be normal, but it may in fact be like at the higher end or the lower end of the scale for obstetric patients.
Perfect. Thank you so much, Dr. Lee. Your presentation was really fantastic. And I'm glad that we had time to address these questions. So thank you so much. And
Thank you.
we will move on to our third speaker, Dr. Klaus Gorlinger. Thank you.
Yeah, thanks. So I'll also share my screen. So should be visible now. And I will focus on the implementation of algorithm. Why is this important? And maybe also point out that it's not about, if you're a rich country or a poor country, I think it's even more about motivation and willingness to change and to improve. And Maggie did already a short introduction of myself. So working at 26 years as an anesthesiologist and intensivist and hemostasiologist. We started with Rotom in 1998. So it's all quite long experience. Actually, University of Essen is using 16 Rotems within one institution. And that was because it was shown in the early years that each Rotem more or less saves for 100,000 euro blood products every year. And in Germany, it's quite simple. The hospital has to pay for everything, for allogenic blood product, as well as for factor concentrates. So in the end, you can see if there is an improvement in outcome and also maybe a cost saving. So what is the journey to success if we want to improve our management? First of all, I think there must be awareness. If we just say, okay, everything is perfect, what we are doing, of course, there's no reason to change. But as we know, there's nearly nothing really perfect in life. And we know that there are overall in the world, there is quite a high number of postpartum hemorrhage. Still, that's of course differs from country to country. And we'll even have a focus on this in one of the next slides. Of course, we need research and knowledge, and I think knowledge is very important because we first have to learn how we should change our practice and not just change it. We also need research and evidence to change guidelines. And of course, postpartum hemorrhage is a very challenging situation, a little bit like trauma, because it's an emergency situation. Therefore, it's not easy to run randomized controlled trials, because if you have to ask a just exsanguinating woman if she's happy to participate in a randomized trial, and maybe she can think about it 1 or 2 hours, this is not really feasible. So therefore, also, most of the evidence in postpartum hemorrhage is based on large cohort studies, as Julie already presented. But finally, even if there is evidence, we even know, and that's not only true for bleeding management, it takes usually at least 5 to 10 years between having recommendation in guidelines and it's implemented at standard of care, because implementation needs a lot of efforts. You have to convince people, you have to change practice, and this is really challenging. And yeah, again, you need a lot of motivation, but in the end, of course, only by implementing it, there is a chance to be successful. And I just want to compare actually two countries, which at the first view, you would say, if you compare Sri Lanka, it's a developing country south of India, or the US, you would say, okay, of course, US, much more resources. It's number one in costs for obstetric management, but it's really also number one in performance. And when we look here at this publication already some years ago, and you may know there was a millennium goal from the WHO, and number 5 was reducing maternal mortality by 75%. There were only 5 countries in the world which reached this millennium goal, and one of this country was Sri Lanka, a small, not really rich country. And when we look at the last year Every Mother Counts report, US was the only industrialized nation with a still rising maternal death rate. So that's a little bit surprising, of course. And when we look here at this data, mainly from 2017, of course, there are a lot of countries, and Australia and New Zealand, as well as a lot of European countries, have actually single-digit numbers for maternal mortality, and usually you don't find them in the CRASH 2 study, because then it's very difficult to reduce mortality. You know, CRASH 2 was done, not CRASH 2 also, but also the woman trial was done in about 20,000 patients. So if you have only 2 mortalities in 100,000, it's very difficult to show a significant reduction in mortality in a population of 20,000, because the chance that you have a mortality in this group is quite low. What is quite interesting when we look here at the numbers from the US, and I did also talk about postpartum hemorrhage 2 weeks ago in Russia, both have a maternal mortality of 17 deaths in 100,000 live births, which is quite high and not much lower compared to Sri Lanka. And again, Sri Lanka did a lot in the last 10-15 years, because 10-15 years ago, they were at the same level as India with 145 deaths per 100,000 deliveries. And now they are down to 36, and the number is every year decreasing. So maybe even in some years, there will be a crossover between the lines of the US and Sri Lanka. And of course, we have still countries in the world like Indonesia, Afghanistan, Nigeria, with very, very high levels or numbers of maternal death within 100,000 deliveries. So again, there is still room for improvement. But coming back to the US, and that's not the data here from Every Mother Counts Foundation, we might have a bias. That's the data from CDC in the US. You see that from 1987, there's more or less a continuous increase in maternal mortality, which is very unusual for countries, for developed countries. And what was found out that there are significant difference also based on the social status. So most maternal mortality is seen in Afro-Americans. So it's not only, of course, the medical treatment, is also availability to health care, which is even in the US not there for everybody. But of course, that's also an issue in India. So looking a little bit more closely to the situation in the US, and colleagues here did some years ago a survey, and sending this survey to all the academic obstetric institutions, and they had a response in 56%. And you might say, okay, maybe if you respond, you have even a higher interest in this topic. But anyway, only 2/3 of all these academic obstetric institution had a PPH protocol available. So that means at least 1/3, even in the academic institution, they don't have it. Or when we look at the last line here, you can do an optimistic calculation, which says 20% don't have one, or you can do a little bit more pessimistic calculation. That would mean even if you extrapolate to all institutions, that maybe even 60% don't have one. So more or less, it's about 50%, which I think is not good. And we have seen even the poll questions that the Australian hospitals are already at a much better level. So one point for improvement could be just to implement a dedicated PPH protocol, which is of course much more than just a ROTEM protocol. That ROTEM protocol is just a part of this protocol. And another point would be also to implement a dedicated PPH team, response team, because we all know if there's a PPH, they can lose a lot of blood in a quite short time. They were even looking more into details. If they have a protocol, what kind of protocol they are using. And as you see here, if they have a protocol, 80% are using just a ratio-based protocol. And we will see this is not really very adequate for postpartum hemorrhage. We can even discuss in trauma, but for postpartum hemorrhage, yeah, we all know that fresh frozen plasma has a very low fibrinogen concentration. So to treat a low fibrinogen level with plasma is not really a good idea. And most of the centers, if they use cryoprecipitate, they use it just on clinical judgment. Or if they measure fibrinogen, they use a quite low trigger, so below 1.5 gram per liter. So they start late. And when we even look at the frequency that they use viscoelastic testing, it's 2.5%. So this is a survey from 3 years ago. So that means, just using ratios, I think is not really an appropriate protocol for postpartum hemorrhage. And there are even quite good data supporting this. So here's a paper published in 2019 in JAMA, so I think a quite good journal. And they were looking, what is the effect on outcome by giving plasma transfusion very early, within 60 minutes of postpartum hemorrhage, within 2 hours, or within 3 hours. And they were looking at clinical endpoints, which is mortality, hysterectomy, or the need for arterial embolization. And I looked for each in isolation or at the composite endpoint. And giving plasma within 60 minutes of start of postpartum hemorrhage was associated with a 50% increase of negative composite endpoint. If we give it within 2 hours, it increased the negative endpoint by 70%. And within 3 hours, it's more than doubled. But there was not any time point or time period where giving plasma transfusion was associated with improved outcome. So that means, yeah, we are still using a product like plasma, which had not even any proven benefit, but has proven a negative effects on outcome, including mortality and hysterectomy. So I think that should definitely let us think again if using a ratio-based approach is really a good idea in this setting. And I think that was already some years ago addressed by Roger Browning and Nolan McDonald from Perth, that fibrinogen, low fibrinogen, and I think Erin and Julie showed this quite nicely, is definitely an issue in postpartum hemorrhage. But it's not just about running a ROTEM test. Of course, we also need the right therapeutic intervention. And again, they already addressed before the JAMA paper was published that fresh frozen plasma is an inappropriate source for fibrinogen, that you have to take care in your institution by, of course, discussion and collaboration with your blood bank, how quick you can get cryoprecipitate or fibrinogen concentrate. And for example, several centers in Sri Lanka, which definitely are not the richest one, use at the first line in between fibrinogen concentrate because the time to wait is much less. And if they need additional fibrinogen, then they move to cryo because it's just in their country significantly cheaper and then easier available. So what is the situation really in Australia and New Zealand? So in principle, yeah, more or less everybody knows. And I think education is not the big issue. Availability should also not be a big issue, that a cryoprecipitate or fibrinogen should be available. But when we look at the real situation, is that, yeah, hysterectomy is still quite often. Of course, mortality is low, which is always good, no question at all. A low fibrinogen below 2 grams per liter is detected in about 50% of cases. We will see later on also that yeah, it depends on the situation. Usually in Europe, we even say it's about 25%. If you go to developing countries like India, where quite often it takes time that the patient even gets to the hospital, it can go up to 2/3. But the interesting point here is that even if fibrinogen deficiency was detected in 52%, from these 52%, only 3/4 received cryoprecipitate or fibrinogen concentrate. And plasma was still the most often used blood product besides red blood cells. So plasma was given in 88%, platelets in 66%, and cryoprecipitate only in 57%. So I think it should be just the other way around. And when you have the numbers in mind, still from the study from Dennis Nigovsky from Yale, also presented by Julie, yeah, they could avoid plasma in 90% and platelets in 100%. So that means it's still, even also in Australia and New Zealand, it seems that a lot of people still use more or less a ratio-based approach. Then even in this registry, they showed that if you give the first dose of cryo after a transfusion of 6 units of red blood cells, so quite late, this is associated with negative outcome again, and that's 3 to 4 times higher. And also, of course, a placenta previa is also a prediction of more problems, as well as the emergency cesarean section. But again, that means we should not start with 1:1:1 and then even at the last resort move to cryo or fibrinogen. This is an intervention we should use as early as we detect it as an issue. Yeah, also when we look here again, that's more or less similar data. When we look at platelets transfused, this is really 2/3 of the patients gets a platelet transfusion, which usually can be avoided. And again, also more than 50% here gets a lower number of fresh frozen plasma, 1 to 5, and even 1/3 gets more than 6 units of fresh frozen plasma. Again, very less efficiency, but associated with complications like TACO or TRALI. And when we look at cryoprecipitate not given, again, about 50%. So that means the most effective therapy is, even in Australia and New Zealand, and also in Europe, not given really as a standard of care. And also when we look what is the percentage of patients with abnormal results, we see again, fibrinogen below 2 grams per liter, about 50%. The others are not really in the beginning very important, because platelet count drops down late, and also APTT and INR is not really predictive for bleeding in obstetric hemorrhage. And again, of course, the advantage of fibrinogen is that it's available in a short time. Of course, also emergency cases, hysterectomy rate is still quite high, but we will see, or you saw already in the studies presented by Julie Lee, that this can be decreased significantly by a better management. Yeah, and again, that I mentioned already is just the corresponding numbers giving cryo late after even 6 hours of red blood cells, that is associated with more or less doubling the hysterectomy rate. So we should do this as early as possible. So there's a question also, if we can identify the patient with coagulopathy, does that have an impact on outcome? And yes, it has. So patients with the coagulopathic bleeding in postpartum hemorrhage, which is between 25 and 50%, that has an odds ratio for massive transfusion 24 times. So it's really important not only to say, oh, this is a postpartum hemorrhage. We also have to differentiate, is that just a uterus atony or is it really a coagulopathic bleeding? Again, hysterectomy increases about tenfold, and also morbidity like tachycardia, lung complications increases tenfold. What we did within the woman trial was even a subgroup in Nigeria, which has the highest maternal mortality, more or less, in the world. And we were looking at this institution. Can we detect the issue with ROTEM? ROTEM was not used here for guiding therapy and not for the decision giving tranexamic acid or not. But the question was how often hyperthyrolysis really can be detected. That's in about 1/4 of the patient population. But when we also look at coagulopathy, which we have seen in the slide before, can help to predict also the severity and outcome, we see that if you use standard lab tests like PET, you only detect coagulopathy in 12%, where if you use ROTEM, you can detect coagulopathy in about 1/3, because PET and PETT gives you no information about clot firmness or hyperthyrolysis. So coming back to Sri Lanka, because they have also, I think, a quite good success story in implementing ROTEM. And that was about 4 years. First of all, they increased the cryotransfusion, because that was identified as a main issue, by 86%. But on the other hand, they also could identify that at least 1/3 don't need cryo at all, and definitely also not fresh frozen plasma, because they didn't have a coagulopathic bleeding. Plasma was reduced by more than 70%, platelets by nearly 50%, and also the overall transfused blood volume by about 50%. They also reduced the need for ICU stay by 45% and hysterectomy by about 10%, and overall costs by about 30%, which is even important for a low-income country. And what is the current situation? Point-of-care ROTEM-guided protocols is used in all PPH cases in Sri Lanka, and since then they have more or less in the hospitals, the big maternal hospitals, no mortality anymore. They have also a long history, because Sri Lanka was one of the first countries in Asia, and that's 150 years ago, where they had their dedicated maternal hospitals. And also about 5 years ago, in their guidelines for postpartum hemorrhage, they already mentioned that thromboelastometry might be useful and will enable a factor-specific replacement, which is, I think, straightforward for a developing country. And now in the actual guidelines from last year, they don't discuss anymore about whether you should use ROTEM or not. They just say you should have your ROTEM results within 5 to 10 minutes and replace blood products and factor concentrates as indicated by ROTEM. So overall, we can discuss how to stop exsanguination, and you can use 1:1:1, which is just refill, but this doesn't stop the bleeding. I think we have to close the holes in the vessels, and this can be done in different ways in obstetric hemorrhage. If it's a bleeding due to uterus atony, we have to use uterotonic drugs, or if it's really a coagulopathic bleeding, we have to use blood products or factor concentrates. We talked about algorithms. We don't go here into the details again, but I think as mentioned already in the talks before, it should be as simple as possible. And I think it's better than to have a two-dimensional protocol or a horizontal protocol, a step-by-step approach. And it always starts, of course, with a clinical situation. And of course, based on the woman trial, at least within the first 3 hours, it's a proof that there is more benefit than harm by giving tranexamic acid blindly after 3 hours after delivery. Yeah, that's not supported by the woman trial, but I think if it's really severe bleeding, yes, I would not wait for the results. But even then we looked at early clot firmness parameters that we can even do the decision in patients which postpartum hemorrhage starts later than 3 hours after delivery to decide early if we give tranexamic acid or not. Then we have clot firmness, but this was already discussed. In some rare cases, we have an issue with thrombin generation, but this is, again, quite rare. And therefore, the need for plasma or for 4-factor PCC is not very often. In some rare cases, we can have something like an endogenous happen effect. There are very, very rare cases of acquired hemophilia. That means we have also to look at the intrinsic pathway, but I completely agree that in most cases, just the extem and the FibTem. But if there is severe bleeding and extem and the FibTem is normal, we just have a look also at the intrinsic results. And again, if there's ongoing bleeding, we have to recheck after 10 to 15 minutes and then run the protocol again.
Dr. Gorlinger, sorry, just a 5-minute reminder for you.
Okay, yeah, fine. These two studies have already been presented, the McNamara study together with Shuba Malaya and the Snigovsky study. It's overall more than 50,000 deliveries. And what I just did was looking at the impact on outcome. There was no impact on outcome on mortality because in both studies there was zero mortality and we cannot decrease zero mortality. But using hysterectomy as a let's say surrogate parameter, you see that both studies reduced hysterectomy by 50% and the need for ICU admission by 87%. And that just shows that you can reduce a lot of complications. We are just awaiting the results of this study. That's the first really a prospective randomized study using Rotem versus non-Rotem group. I can tell you already there will no reduction in mortality again, because also in this 100 patients, there was fortunately no mortality. So it will show quite similar results as the cohort studies presented before. So to summarize, I think most women with postpartum hemorrhage do not develop a coagulopathy. So that's not in all these patients. It's between 25–50%. If we have to replace fibrinogen, we should use an adequate source, which is cryo or fibrinogen concentrate. It's not fresh frozen plasma. And viscoelastic testing can provide very quickly results which can discriminate between the coagulopathic and non-coagulopathic bleeding. And this, of course, has also impact on the guidelines from the ISTH published in 2016. First of all, they announced that the results are available sooner, and by identifying what is the reason for bleeding, is that coagulopathic or non-coagulopathic, this helps also for further decision making. And it's the first guidelines who are used or doing an approach like what you should not do. And that means if FibTem is higher than 12, you should not give fresh frozen plasma, and you also don't have to give fibrinogen concentrate or cryo. So this should be done just in the patient with a low fibrinogen. And even in the US, which I think are still at a level with 17 maternal deaths within 100,000 patients, yes, they now more and more identify that's time to move from a ratio-based to a teragnostic approach. So first measure and then just give what is needed. Of course, in the UK, are more straightforward, in particular in Wales, where they did all the OPS studies. And even they say that in a labor ward, point of care testing should be mandatory. But again, it's not just enough to say we should do, we have to do. And this is what they did in Wales with the OBSTETRICS project, that they really implemented point of care testing in every obstetric department in Wales. And here they have a PPH protocol. Again, ROTEM can only be a part of this protocol. And since also in UK, you have two sources, cryo or fibrinogen, they have two different algorithms, which just have the fine tuning if you use cryo or you use fibrinogen concentrate. That's one from Perth. So there are a lot of algorithms available. More or less the numbers are in between very similar because they're based on evidence, but the presentation of an algorithm can be different. So really to summarize what the preconditions that a goal-directed approach is working. First of all, it's good to have a ROTEM, but just to have it is not enough. We need really the results back to the clinician or do it at the point of care, but we need the results in 10 to 15 minutes. We need some education that we know what we see, and algorithm implementation can help that even a non-hemostasis expert can just do it step by step. And we all do in anesthesia intensive care in life-threatening situation working with algorithms. And it's of course important to change your transfusion practice. If you just do what you did before, just with measuring a ROTEM, it will not improve outcome. But by moving away from blood products, which are not very helpful, like plasma, in particular in this situation, and if needed, use factor concentrates, the studies show that there is room for improvement in outcome. Yeah, and then I'm open for questions, and just keep calm and not just refill. Please stop bleeding. And this is important, to have a better patient outcome. And thanks for your attention.
All right, thank you so much, Dr. Goerlinger. That was a really fantastic presentation. Lots of really good points about implementation and good guidance there. We're pretty much out of time. Does anyone have any last questions or comments before we close the session? Anybody? Okay, well, thanks to all of you who did submit questions throughout the session. It looks like we've addressed everything. Oh, is there a hand up there? Do we have a question from Carol Joy? Maybe that was an accident. Okay, so yeah, that concludes tonight's event. We hope that you all found the meeting to be instructive and insightful. A couple last points. We will be at ANSCA. We'll be in a virtual booth. So please come say hello to our virtual booth, and hopefully we'll see some of you then. We also have our Rotom in Obstetrics workshop next Wednesday. So if you're interested in learning more about interpretation, please join us next Wednesday. We did send the link out for you to register. So hopefully we will see many of you virtually next Wednesday as well. We will follow up with that survey, as I mentioned. So please let us know what you think of these events. And thank you again so much for taking time out of your busy evenings to join us. Once again, I'm Maggie from our whole Work in Australia team. Thank you so much to all of you. Take good care. Thank you so much, Dr. Goerlinger. As always, we're always so grateful. We're so appreciative for your time and your expertise to share with us. So thank you again. Have a good night, everyone. Take good care.
Bye-bye. See you maybe next week.
Yes. Hope to see many of you next week.
Thank you very much. Bye-bye.
Bye-bye.
Thank you, Hannah. Thanks, everyone.
Thanks. Bye.
Thank you. Take care.